and I'm honored to introduce this year's 2021 Stanley Fahn Lecture Award recipient, Dr. Oscar Gershanik. Dr. Gershanik is professor and scientific director of the Institute of Neuroscience at Favaloro Foundation University Hospital in Buenos Aires, Argentina. He is also the Emeritus Director of the Movement Disorder Unit and Emeritus Consultant, Laboratory of Neurobiology of Parkinson's Disease, University of Buenos Aires, and Laboratory of Experimental Neurobiology, Entre Rios University. Oscar and I have been friends for decades. He and I have followed similar career paths in our development, starting in laboratory research in neurochemistry and neuropharmacology, followed by clinical investigations, including experimental therapeutics. In one of my first professional meetings in Buenos Aires about 4 decades ago, Oscar invited me for dinner with his wife and him in his home. I mention this to point out how warm and friendly he is, in addition to him being an outstanding clinical scientist. Oscar has been involved in different capacities within MDS for many years and served as president of the society from 2015 to 2017. He currently serves as chair of the International Congress Oversight Committee and advisor to the MDS Education Roadmap. Please join me in congratulating and welcoming Dr. Oscar Gershanik. Thank you.
Good day, everyone. I really would like to extend my thanks to the organizing committee for bestowing upon me the honor of delivering Stan Fahn's presidential lecture at this meeting in 2021. The title of my talk is Opening the Pandora's Box of Parkinsonism. And as I'm just a few months away from celebrating my 50 years as a doctor, I think it is the right time to honor those who had a significant influence in my career. I would like to start with my father, Dr. Simon Gershanik, a pediatrician who, through his example, showed me what a doctor should be. Professor Thompson was my mentor in my training years, and he taught me the art of neurological examination. Both Melvin Yar and Roger Duvoisin are the ones who introduced me to the fascinating field and world of Parkinson's disease and movement disorders. And finally, I would like to mention Stan Fahn, the name of this lecture, who is the mentor above all mentors to most of my contemporaries. He's the memuneh, as the old Hebrew word says, the one, the chosen, the unique. And rumor has it that Moses himself handed Stan the tablet with the 10 basic principles of movement disorders. Therefore, for me, it is an honor to give this named lecture dedicated to him. Thank you, Stan, for all you have done for the society and for your exemplary career and the example you have provided to all of us who work in the field of movement disorders. As I told you, the title of my talk is The Pandora's Box of Parkinsonism. Why is that? Because the meaning of the Pandora's box, according to Greek mythology, is that when you open the Pandora box, that means the start of trouble. And every time we see a patient with Parkinsonism for the first time, I believe that is the start of trouble. And why is that? It's because the universe of Parkinsonism, ever since I started my career 50 years ago, has been continually expanding and giving evidence of complexity, heterogeneity. And that's why I would like to present a new and revamped iteration of my recent MDS Presidential Perspective webinar, but this time to a larger audience. You know, when I started my career in the beginning, it was rather easy because we had very few options within the field of Parkinsonism to diagnose. Presently, Parkinsonism has become a true Pandora's box. If you look at the development of our knowledge in Parkinson's disease and Parkinsonism, you can see that this world has expanded exponentially along this last 100 years. And now we have so many entities that present themselves with Parkinsonism that we need to organize our way through this true maze of differential diagnosis. That is because every patient we see with Parkinsonism poses a diagnostic challenge. Not only because not every Parkinsonism is Parkinson's disease, but because not every case within the spectrum of Parkinsonism presents itself with Parkinsonism. Sometimes it can be something quite different. And one of our major limitations is the lack of specific biomarkers. So therefore, the diagnosis of Parkinsonism is done mostly through pattern recognition, and we need diagnostic criteria that are based on the recognition of these typical and distinctive features, patterns, and supportive features. I thought that it becomes necessary to have a detailed taxonomy providing us with a diagnostic framework and a roadmap to achieve a correct diagnosis. And the taxonomy that I proposed in my presidential webinar, and I will be proposing now to this larger audience, was inspired by a paper published several years ago by Stanley et al. That provided some insight into what is typical and what is atypical in certain types of Parkinsonism. And I have taken the liberty of expanding that concept to the entire universe of Parkinsonism, because I believe that allocating each and every one of the patients with Parkinson's disease or Parkinsonism to one of the different classification slots helps us in defining the diagnostic roadmap that we have to follow. The fundamental question, therefore, is what is typical and what is atypical in this Pandora's box we call Parkinsonism. The first slot in my taxonomy, it's what we call typical Parkinsonism, and that equates to idiopathic Parkinson's disease, of classical presentation, tremor dominant or akinetic rigid dominant with asymmetry, slow progression, lack of atypical features, supportive non-motor criteria, and often, and most of the time, a clear-cut response to levodopa medication. But we also have some atypical presentations of what we call typical Parkinsonism, such as unilateral isolated tremor, postural instability gait disturbance phenotype of Parkinson's disease, the PIGD, and dementia with Lewy bodies. And this I put in a slot I have called atypical typical Parkinsonism. What are the phenomenology caveats to this first slot? We have to first remember the 5-year rule. What does this mean? It means that when we see a Parkinsonian patient for the first time and we diagnosed idiopathic Parkinson's disease, we have to bear in mind that for the first years in the course of the disease, things can change, and patients may initially appear to be typical, but they can change during the course of the disease and lead you in the direction of any of the atypical Parkinsonisms. So we have to bear that in mind, that every time we see on a follow-up visit one of the patients we have diagnosed with Parkinson's disease, we have to re-examine them very carefully because they can turn to be something else. What are the typical atypical Parkinsonisms? That is the second slot in my taxonomy. The typical atypical Parkinsonisms are multiple system atrophy, PSP, and corticobasal degeneration. And we know they have certain distinguishing clinical features. Multiple system atrophy is a multisystem disorder with Parkinsonism, ataxia, and autonomic dysfunction. Olfactory loss is absent. RBD is frequently present. We have postural abnormalities like the Pisa syndrome, the disproportionate anticolis, the camptocormia, and there is variable or poor response to levodopa, and they may present initially as MSAP or MSAC, uh, predominantly Parkinsonian type or predominantly cerebellar type. Within this same slot of the typical atypical Parkinsonisms, we have the progressive supranuclear palsy with early postural instability and falls, supranuclear vertical gaze palsy, symmetric akinetic rigid syndrome, frontal and subcortical dementia and pseudobulbar palsy, and additionally extensor neck posturing, facial dystonia, and frontal release sign. When we see all these things together, this is the typical presentation of one of the typical atypical Parkinsonisms. And the third one is corticobasal degeneration within this slot of the typical atypicals, with an asymmetric akinetic rigid Parkinsonism, dystonia, and myoclonic limb movements associated with cortical symptoms such as ideomotor apraxia, alien limb phenomena, aphasia, or sensory neglect. And once again, when we see this whole pattern, we can say this is corticobasal syndrome. Why is that? Because many other disorders can present with a corticobasal syndrome, among them corticobasal degeneration. But the next lot in my taxonomy is the atypical presentation of the typical atypicals. And these I call atypical, typical, atypicals. For example, the MSA variants, like the minimum change MSA, the benign MSA or PD mimic, the recently described MSA PSP mimic, and all these have certain peculiar features that are different from the classic typical presentation of these atypicals. That is why we call them atypical, typical, atypicals. We also have some atypical presentations of another typical atypical, such as PSP, and these are the PSP variants, like the PSP Parkinsonism with asymmetric Parkinsonism with rest tremor and response to levodopa, the PSP CBS with the corticobasal syndrome, the PSP PFG with global akinesia and gait disturbance, the PSP PNFA with prominent language disorder, language apraxia, and progressive non-fluent aphasia, and many other variants like the one with postural instability, the pure oculomotor, the ataxic form, the ALS-like, etc. So we have to bear in mind all these atypical presentations of one of the typical atypicals such as PSP. And the same is for corticobasal degeneration. We also have atypical presentations of this typical atypical, like this, the typical is the CBS, the corticobasal syndrome, but we also have the frontal behavioral spatial syndrome, the PSP-like syndrome, the posterior cortical atrophy, the dementia of the Alzheimer's type, and in view of the great clinical variability and multiple etiologies presenting with this corticobasal syndrome, the possibility of antemortem diagnosis varies from 25 to 50% only. So this is one of the most difficult types of Parkinsonism to recognize. And we know that this corticobasal syndrome can be seen not only in corticobasal degeneration, but in PSP, but also in Alzheimer's disease, in Pick's disease, in frontotemporal lobar degeneration, in stroke, which is the great pretender, and even in Creutzfeldt-Jakob disease. So once again, this is one of the most difficult Parkinsonisms to diagnose because we are never sure unless we see the pathology what we are facing. And then the fifth slot in my taxonomy is the atypical atypicals. And in this category, we put all the Parkinsonisms that do not belong to the previous four categories. And this is a wide range of disorders mimicking idiopathic Parkinson's disease or typical atypicals that may present with distinguishing clinical features that may provide clues to the etiology, but based on the clinical phenomenology, the clinical course, the family history, the typical neuroimaging findings. And included in this fifth slot of my taxonomy, we find secondary Parkinsonisms such as vascular Parkinsonism, normal pressure hydrocephalus, different genetically determined conditions like the SCAs, the HSPs, pallidopontonigral degeneration, Perry syndrome, certain neurometabolic disorders, either genetic or acquired, and mitochondrial disease. One of the caveats we have to bear in mind and remember is that phenomenology is not quite specific. And that's why sometimes typical or typical atypical phenotypes do not preclude the possibility that they correspond to what I call atypical atypicals. Therefore, we need to be careful in history taking, both personal and family. We have to carefully review the existence of systemic involvement, and we have to perform a comprehensive neurologic examination looking for additional distinguishing or atypical features. What are the clues for the recognition of these different types of disorders? When do we suspect we're faced with an atypical Parkinsonism, whether it's typical atypical, atypical, typical atypical, or the fifth slot in my taxonomy, the atypical atypicals? We have to see the age and mode of onset, the presence or absence of family history, the clinical course, the clinical phenomenology, the imaging findings, the pharmacological response to levodopa. And in some suspicious cases, they may require specific lab determinations like urinary copper and ceruloplasmin in Wilson's disease, cholesterol to cholesterol ratio in CTX, etc. And according to the age of onset, we have early onset cases like most of the genetically based Parkinsonism, some of the catecholamine metabolism disorders, some of the SPGs, Wilson's disease, Niemann-Pick type C, Huntington's disease. And in advanced age, we have the isolated senile bradykinesia, frontal dementia, vascular pseudoparkinsonism, and normal pressure hydrocephalus. These are just examples of the classification according to age. Also, we have to look at the mode of onset, and we have some cases with sudden onset, probably due to stroke, onset with instability and falls like dementia with Lewy bodies, PSP or MSA, onset with psychiatric disorders like frontotemporal lobe dementia, Huntington's disease, Wilson's disease, DLB, with dysarthria in MSA and PSP, with limb apraxia like CBD or CBS, with hallucinations like DLB and dysautonomia in MSA and DLB. What about the family history? We have some cases which have a dominant family history like FTD-ALS, Perry syndrome, some of the SCAs like SCA2 and SCA3, genetically based CJD, and early onset Alzheimer's disease. But we have others that have no family history or have a recessive genetic transmission like Gaucher's disease, Niemann-Pick type C, or mitochondrial disorders, Kufor-Rakeb, CTX, FAXTAS, or HSP. And also we have to look at the course of the disorder, not only the mode of onset. And some of the disorder may follow a stepwise course, and this is very typical of the vascular pseudoparkinsonism. Whereas a rapid course to maximum disability in a few chairs, it's almost typical of MSA, PSP, rapid onset dystonia, Parkinsonism, and most of the atypical atypicals. And also we have to look at the onset of dementia, and according to our criteria, dementia within 1 year from onset or at the same time, it's a clue for the suspicion of dementia with Lewy bodies. We also have to look at the clinical features, and I'm not going to deal with all the different types of phenomenology we can encounter in some of these atypical disorders, but you have to look for pseudobulbar syndrome, cerebellar syndrome, dystonia, alien hand syndrome, apraxia, agnosia, aphasia, palilalia, echolalia, myoclonus, the presence of incomplete Parkinsonism. This is very important because if you find only pure echinacea, isolated unilateral tremor, lower body Parkinsonism, the presence of depression, weight loss, and central apneas, as we see in Perry syndrome, the presence of pyramidalism and spasticity, as we see in some of the pallido-pyramidal syndromes, like Kuforake, part 14 and 15, some of the spastic paraplegias like SPG11 in vascular Parkinsonism, the presence of oculogyric crisis like we see in some of the catecholamine metabolism disorders, and also the presence of cognitive deterioration and dementia, as we see in many cases like FTD, CBS, DLB, HD, PSP, etc. What are the caveats of phenomenology-based diagnosis? Some cases of atypical, typical, atypical Parkinsonism, and likewise, some cases of atypical, atypical Parkinsonisms may present with the clinical features that are indistinguishable from typical Parkinsonism, idiopathic Parkinson's disease. That is the reason behind the 5-year rule. That's why you have to keep examining your patients in the follow-up visits to look for the presence of atypical symptomatology. And moreover, response to levodopa may be present. For example, in PSPP, progressive supranuclear palsy with a Parkinsonism phenotype, with a Parkinson's disease phenotype, there can be a significant response to levodopa. And even in some cases of MSA, I have seen some of the best responses to levodopa in some of my MSA cases. What about imaging? What is the contribution of imaging? This is a very, very complicated table, and I will not go into detail looking at all the typical things that have been described as characteristic neuroimaging findings in some of the atypical syndromes. I only want to tell you about the limitations of neuroimaging-based diagnosis. First of all, suggestive imaging findings may not be present at all. And when present, they may become evident late in the course of the disease and not be helpful in an early diagnosis. And they are not always highly sensitive or specific. So when we find on an image a typical finding, it's like hitting the lottery, because not always that is the case. What about therapeutic response to levodopa? And according to that, when we find a case with an initial therapeutic failure, it may be that we are in front of a case of MSA, PSP, CBD, and most of the atypical atypicals, with exceptions, because even some of the Parkinsonism associated with SCAS or with the hereditary paraplegias can respond to levodopa, and some of the catecholamine disorders, and most of them, can present with typical Parkinsonism and have an excellent response to levodopa. But it is important to know that a rapid loss of therapeutic response is highly characteristic of some of these atypical conditions like MSA, PSP, and the atypical atypicals, with exceptions, as I mentioned before. And finally, and repeating what I said before, when you have a great response to levodopa, this can be one of the catecholamine disorders like dopa responsive dystonia, and some of the cases of genetically determined juvenile Parkinsonism, for example, Parking mutations. And you have to bear in mind that a negative initial response to levodopa does not mean that you are not facing a case of typical Parkinsonism, while a positive response to levodopa does not confirm Parkinson's disease or typical Parkinsonism. And there are many publications that attest to this limitation. One of the most recent ones is the publication by Wayne Martin et al. In Movement Disorders in 2020, in which they found that 52% of those with autopsy-confirmed multiple system atrophy and 44% of those with autopsy-confirmed progressive supranuclear palsy had marked to moderate response to dopaminergic therapy. And in the series by Hughes et al., when they studied their 100 clinical pathologic cases of Parkinson's disease, initial response to confirmed cases of Parkinson's disease was null or poor in 6%, moderate in 17%, good in 53%, and excellent in only 24%. So bear that in mind. A negative initial response to levodopa does not mean that that case is not Parkinson's disease, and a positive response to levodopa does not confirm Parkinson's disease. And to finish, I like to present my full taxonomy and the full roadmap. Clinical history taking and full neurological exam are crucial. When we have a typical exam, we have the typical Parkinsonism, but remember the 5-year rule. When we have an atypical exam, we can have atypical presentations of idiopathic Parkinson's disease, and I call them atypical, typical Parkinsonism. You can also have a typical presentation of atypical Parkinsonism, and I call those typical, atypical Parkinsonism. And you can have also an atypical presentation of typical, atypical Parkinsonism, and I call those atypical, typical, atypical Parkinsonism. And finally, that whole universe of all the cases of Parkinsonism that do not belong to the previous categories that I call atypical, atypical Parkinsonism. And in our history taking and in our exam, we have to include the age and mode of onset, the family history, the clinical course, the clinical features, the imaging findings, and the response to levodopa, with all the caveats that I mentioned before, that some of the atypicals may be phenotypically indistinguishable from idiopathic Parkinson's disease, and they can even respond to levodopa. Thank you. It has been truly an honor.